Next up is Rebecca with the Wisconsin Chiropractic Association. And if there's more that you want to join you, that's fine too.
Oh, thank you. Green light. Okay. Hello, Chairman Quinn and committee members. My name is Rebecca Lahman. I am the office manager and chiropractic technician at my husband's private practice in Monroe, Wisconsin. We've been in practice for 10 years. We're very grateful. A large part of my job is insurance, and that's why I'm here. I submit the prior authorizations. I'm the only one that does them. So I have the same issue in my office. If I'm not there, everybody goes cattywampus. The prior authorization is hindering our ability to provide the best treatment options to our patients, and it's getting worse. Patient care is our top priority, but that becomes secondary by default because of this process. I've provided an outline for everyone's reference that gives a lot more detail. I'm just going to kind of squish it into a short little speech here. The average turnaround time for us is 3 to 10 business days for most payers. Some will approve everything, or some will give us a partial approval. Some will require a PA for just chiropractic spinal manipulation, which is an adjustment. Some will require, we also provide chiropractic modalities and therapies in our office. Some will require a PA for each individual procedure. Some will give me an approval for just adjustments. Others will give me an approval for an adjustment and one therapy. Some will give me no therapies. There's a lot of variables involved, and there's no consistency. Okay. We can paint the best picture possible, but it is still up to an algorithm on the other end. We use technology in our office. I do not use smoke signals. We do everything on online portals, and we do have a very large payer base. So I am very familiar with the process. I know the ins and outs of everything, and I know how it's going to work almost before I have to submit it. I can say with confidence that less than 10% of the payers we work with have a human being on the other end that is receiving the request. The majority of them, when we submit it on an online portal, we are putting in a diagnosis code. That diagnosis code, in most cases, an average patient will have anywhere from like 5 to 8 diagnosis codes. We can only usually put in one, and we usually don't know which one is going to give us the best outcome or help us convey the message we want to give, okay? And then out of all of these payers, less than 10% have a doctor of chiropractic, a chiropractor on the other end receiving that information, and they pop it into their computer. It's all based on an algorithm, so on and so forth, if this patient has ever been seen before, et cetera, and then we get a response. The other percentage of payers we work with, usually it's an immediate response. So that is AI driven. That is not a human being receiving it, evaluating our statement, looking to see our description in the story of that patient's condition. That is an immediate response based on supposed coverage or benefits that a patient has for their policy, where they might have up to so many visits, okay? So that's a very big issue for us, because patient care is not per patient, it's just an algorithm. How can an algorithm determine what the patient really needs? There's no conversation to fully understand their problem. There's no eyes on the patient to see how they're moving, seeing if they're in pain, seeing what they can and can't do, and addressing their ADL dysfunction. In most cases in our office, one of two things will happen. The patient will either choose to wait for the decision, symptoms get worse, and by the time we get an approval or partial approval, now we're already chasing our tail. And we have to work twice as hard to try and get them better, and we're also getting less visits than what we requested. The second issue is a patient might choose to get treated knowing they don't know if it's going to get approved. So now we have an additional cost there where they might have to pay out of pocket for a service that they are told by insurance representatives when they call and check their own benefits, that they are told by those representatives that, oh yeah, it's covered, but it's really not. So that's the other thing that I find really interesting. So we talked about, or we heard, I should say, about transparency. Where's the transparency in that statement? If a member comes into my office and I educate them, so I'm really big on education and making sure patients know the ins and outs of everything, good, bad, and indifferent. When they are told that they have to have this prior auth, well, I thought that the chiropractor would be covered. And I said, well, no, this is what we have to do. In most cases, they get frustrated or they get upset because they're already in pain, and now they have to fill out 1 to 3 pages of paperwork with questions that frankly are very vague and can't really address their symptoms the best. And then what ends up happening is they go home and they call their insurance, and then they call me and they say, Becky, my insurance says that I can do this. All you have to do is submit this paperwork and then they'll approve it. Nobody is educating these people except for us, providers, our offices, on the fact that that's really not the case. So there is a lack of transparency there too that definitely needs to be addressed. My question to all of you is, how does this benefit the patient? How does the pre-auth process benefit the patient? The cost for someone to see us and get better and possibly avoid hundreds of thousands of dollars in surgeries and injections, and more often they still come back to us afterwards anyways because it didn't help. How is that more cost effective? We're not expensive. My other question to you guys is, would you be willing to wait? If you were in pain or you had a family member in pain, would you guys be willing to wait? Or would you succumb to the process that, well, I don't really want to do this, but I think I might have to go get a steroid injection in my back because I don't know how long it's going to take for me to get this approval? Are you guys okay with that? You guys are patients somewhere too. Would you be willing to pay for services that are supposed to be covered and that you are told by your insurance are covered? Most of this sounds like an administrative headache. And it is. But it all affects patient care, which is our top priority. To be blunt, it doesn't make sense. If this bill was passed, we could provide the care we needed from the start. Doctors can provide the treatment plan needed. Patients can get better, and the cost to the insurance company is significantly less compared to more invasive methods. I'm going to now hand this over to Dr. Mackey. I do appreciate everybody's time. I thank you for listening to me. I will make myself readily available to answer any questions. I can provide a lot of information if anyone is interested. And thank you again for your time.
Thank you. Chairman Quinn, members of the committee, thank you for the opportunity to speak here today. My name is Dr. Jason Mackey. I am a managing partner of a chiropractic group here in the Madison, Wisconsin, along with a natural medicine group as well that employs physical therapists. So we see both sides of what's been discussed here today. Just to jump in, because I know there's going to be a question coming from Chairman Quinn about why 12. I wanted to just touch on that from the chiropractic side of things. To start with, as far as an actual care plan goes for acute care patients that are coming into a clinic, 12 is considered a standard treatment plan from the start from a chiropractic point. It goes 3 times a week for 2 weeks, 2 times a week for 2 weeks, 1 time a week for 2 weeks. So that's kind of a generalized care plan that we use with patient care, okay? Now, that does not mean that they get 12 visits, okay? That's what we start with, as a general idea of what the outline is going to look like for them, but patients change as far as when they go through care. So, because you like data, I thought I would actually pull some for you here real quick. I hate to say this when I'm here and I have to testify, but 2 months ago I hit 20 years in practice, so I've been doing this for a little while. Estimate right now is that I have had about 250,000 patient encounters during that time frame, okay? My patient visit average after 20 years is 8.06. So I've been doing this for quite a while, seen quite a few people. My average is about 8. Well, then why do I need 12? Because some people need 12. That's an average, which means that that's kind of where most people are going to sit, but you're going to have both sides of the bell curve here. Some people are less than that, some people are more than that. By saying 12 in a chiropractic standpoint, which I think my physical therapy colleagues would agree with, this gives us the best opportunity to get the patient care done treat that episode of care, get them better without having to go through the hoops of pre-authorizations for that patient, okay? So I thought that was a great question that you asked, so I wanted to kind of touch on that right away. You'd asked about, well, will this increase care utilization? From the standpoint, again, with what our PT colleagues were talking about, I've never seen this from my standpoint when I refer out for physical therapy as an issue of trying to get in for more visits. There's just not enough PTs to go around for everybody. And so they need to get more people in. So the push and emphasis on that has always been, we have too many patients and not enough people to serve them. And so get more people in because there's a lot of people waiting in the wings. Right now, if I refer out to some of the systems that are in town here, it's a 6 to 8 week wait for me to get people into physical therapy. Mm-hmm. That's a long time. One of the comments that was made earlier was that CMS is making some changes start of the year. 72 hours for urgent cares, 7 days for other care. I don't know how many of you sitting at the committee here have had spine pain, neck pain, blown out a knee, ankle, whatever it is. Folks, pain is a heck of a motivator. People are not going to be waiting 7 days when they have an 8 out of 10 pain. They're going to be going to urgent care. This is going to increase overall utilization of opioids. It is going to reduce the utilization of conservative care because they're going to be waiting for that rather than getting in for that. We know this from studies that are out there. And if you'd like, I can actually, I know WCA has studies with regards to some of these, but I have studies as well that show conservative care radically reduces the utilization of opioid utilization. So this is something that is very helpful for our constituents and people out in the state here. I'm not going to go through all of the things that all the other people have already talked about. We know that this is frustrating. We know that this is a burden. We heard one of the larger systems talk about the overall cost for some of the bigger systems that are out there. I want to just give you one last little bit from data standpoint as far as a smaller window on this. So within our group, we took a look for one payer over a 9-week time frame. During that time frame, we had 350 patient submissions. The average time frame at the front desk with the patient filling out the paperwork, working with our front desk person, was 25 minutes. The average time frame for the doctors to fill out their portion of the paperwork is approximately 10 minutes. The average time frame for our RCM people, our people in the revenue cycle, was about 20 minutes working with the billing. So in total, every episode of this was approximately 55 minutes of time to submit each one of those patients. Of that, we had 34 of the 350 people got denials, the vast majority of which were simply syntax errors that were sent in, that there was a mistake made on the payer's part, and we had to resubmit, which then meant another 20 minutes of front desk time talking to the patient, working through it, resubmitting, and a 35 minutes of increased time on average with the RCM team having to be on the phone trying to talk to the people to get these things taken through. If you average that out for those 350 people, that was 465 hours of time for 350 patients over 9 weeks. If we average that out at approximately $25 an hour, which is what our average would be when you put doctors and staff all together, that comes out to about $11,625 for 9 weeks. That's one clinic group. Okay, average that out amongst all the clinic groups of chiropractic, physical therapy, occupational therapy. It starts to make some real numbers here. I've heard you ask the question about the premiums and the increasing premiums and whether or not that would actually be something needed to be done. I understand where some of that concern comes from, but at the same time, if we eliminated these issues as well within our hospital systems, our medical clinics, and even the insurance companies need to be monitoring this, wouldn't that reduce cost? Wouldn't we not need to raise premiums because we've eliminated cost that was not needed in the first place? So with that, I will leave my testimony and answer any questions as you have for me.
Well, that would eliminate costs on your end, right? Then the question is, from the insurer's side, would you pass that on to the consumer in terms of the billing?
But I mean, how many people are they employing to actually take care of the pre-authorization side on their side? They have doctors that are sitting on, how much does it cost per doctor to be reviewing these when they do have doctors reviewing these? So no, there would actually be cost savings on that side if they didn't have to be doing that as well. That would only make sense.
Valid point. Other questions from committee members? Hearing none, thank you for taking time off your day and coming.
Thank you, everybody.
Yep, thank you. Next